Understanding lipedema, beyond the fat. Treatment options explained. Imagine eating a perfect diet and exercising every day, yet the fat on your legs and arms refused to budge. For millions of women, this isn't a lack of willpower. It's a chronic medical condition called lipedema. The definition. Lipedema is a painful fat disorder where diseased adipose tissue builds up disproportionately, usually in the lower body. Today, we are analyzing why traditional weight loss fails and exploring the medical treatments that actually work. Why traditional weight loss fails? The biological difference. The first thing we must understand is that lipedema fat is fibrotic. Unlike normal fat, which the body uses for energy, lipedema fat is resistant to calorie restriction and cardio. This is why many patients have a thin upper body but significantly larger legs. The pain factor. Lipedema isn't just a cosmetic issue. It involves the lymphatic system and small blood vessels. This leads to easy bruising, tenderness to the touch, and a heavy tree trunk sensation in the limbs. Non-surgical management, conservative therapy. Managing the flow. While there is currently no permanent cure, conservative treatments focus on managing symptoms and slowing progression. The gold standard is complete decongestive therapy, CDT. Key tools. 1. Manual lymphatic drainage, MLD, a specialized massage that moves trapped fluid back into the lymphatic system. 2. Medical-grade compression. Wearing flat knit garments is essential. These don't burn fat, but they provide the pressure needed to reduce pain and prevent the condition from worsening. Anti-inflammatory living. Diet does play a role, but not for weight loss. Anti-inflammatory protocols like the RAD diet, rare adipose disorder diet, focus on reducing swelling and pain by avoiding processed sugars and chemicals. Surgical options. Specialized liposuction. Not your average liposuction. When conservative methods aren't enough, surgery is an option. However, this is not standard cosmetic liposuction. It requires a specialized technique called water-assisted, wall, or power-assisted, PAWL, liposuction. Protecting the lymphatics. The goal of lipedema surgery is functional, not aesthetic. Surgeons use blunt cannulas and specific mapping to remove the diseased tissue while
Lipedema, we're going to talk about it today and specifically how to treat it if you have it. I'm Dr. Paul Zalzal.
I'm Dr. Brad Weening. Welcome to Talking with Docs. We have a guest, a returning guest, Dr. John Chubak from the Jersey Shore.
Dr.
Maybe
Chubak
not quite the shore.
is
I don't really
back.
know the distinction.
From North Jersey.
Okay,
He's
there
taking
you
a
go.
break from his show, The Real Surgeons of New Jersey.
That's right.
To be with us today.
It's a pleasure, guys.
Thanks for coming, John. Okay, so we've done a previous video about lipedema, but it was more about identifying it and addressing a little bit what it is. But today we're going to talk more about the treatment, and particularly the more invasive side of surgical treatment. But let's start at the beginning, just a refresher for people. What actually is lipedema?
Well, lipedema is a fat disorder that we are learning more and more about. And again, we did a video on this that got tremendous response because there are a lot of people suffering from this problem that have been largely neglected and marginalized, quite frankly, from in the medical community and socially as well. So generally, we believe that it's genetically transmitted. There's no known gene for it yet, but we definitely see that it's running in families. Anywhere between 20 and 60% of patients have a strong family history. And it's basically a very abnormal deposition of fatty tissue on the body. And there are a few types we can talk about and a few stages we could talk about quickly just to review, but most physicians have no idea that this is a real disease, and these patients are basically told that they're obese, and often they will have an elevated BMI, 35 or above, but it is not normal obesity, and you can see that through physical examination when you are really well trained as a physician to pick this up. So that's
on behalf of the medical community, sorry that we didn't know about this sooner. If you have had a bad experience, we apologize. But at least we're making the video now to try and clarify this, that it's genetic, a big genetic proportion of it actually, that's a pretty high number, and not should not be clumped together with typical obesity that we most commonly refer to. So this is sort of a specific type of disorder with fat deposition.
And what's interesting is that histologically, it's different kind of fat, right? It's not normal fat. So when they look at it, there's more fat cells. The fat cells are bigger, as well as the fat cells are kind of wrapped in like a fibrous kind of mesh almost.
Exactly.
And they think this is what makes it more painful.
Exactly. It's clearly at its core, like so many diseases that we know about now, inflammatory in nature. So we know that it's almost exclusively in women. There are some men who get it, but it's almost exclusively in women. And besides being genetically linked, hormonally linked, we know that the disease sort of declares itself or reveals itself at major hormonal moments in a woman's life: puberty, pregnancy, and menopause. So, and even there have been cases with birth control pill, which has hormone in it. So we know there's a hormonal link also, but it's definitely different than plain old obesity, for sure.
And the main issue with this is probably twofold, right? So there's a cosmetic concern, so people don't like how it looks. But the other concern is that it's actually sore. This causes these people pain and discomfort and debilitation.
Yeah, and actually as orthopedic surgeons, this is kind of interesting to you, I would think also. There's also a functional component, especially when you get into more advanced stages of the disease, like stage 3. Patients develop what we call lobules or wattles. They can be very, very large, very sort of aggressive, impressive looking outpouchings of fatty tissue around the hips and often in the inner knees. And you also often see a lot of knock-knee kind of body habitus in these patients. So mobility and ambulation become a problem. Walking becomes a problem, quite frankly, getting around.
And it's a vicious circle because the associated elevated BMI also puts an increased load on the joints, which does wear them out faster.
Exactly.
So so you've got this, someone has this, some of our viewers might have this. What can we do about it? What are some treatment options?
Well, like everything else in medicine, we try to start slow and start with the things that are conservative and non-invasive. But that's why I think this video is going to be so important, because quite frankly, I see a lot of people with lipedema in my office. And in early stages, especially stage 1 and 2, those conservative measures like compression, exercise, a lot of non-weight-bearing exercises because of the joints, Paul, that you mentioned. Swimming, for example, is one of the highly advocated exercises for people with lipedema. These things are helpful in getting lymphatic flow going, hopefully burning some extra calories, helping the patient to control their BMI. We've talked about before, Brad, anti-inflammatory diet and these kinds of things to bring down that inflammatory underlying issue.
Right.
So compression garments, actually mechanical compression garments, as opposed to just stockings. So all of these things are valuable. But there does come a point at which you see patients and you know that that's just not going to help them, especially in changing their appearance and body habitus. Those conservative measures, and this is one thing we should never forget, at its core, lipedema is not just a cosmetic issue. There's a lot of pain that comes along with this. And these people get dismissed that the pain isn't real, which can also lead to a lot of anxiety and depression in them. So,
which then again makes the pain worse, and again another vicious
cycle. Correct.
Okay, so you mentioned when these conservative methods don't work, some more invasive treatments. Can we talk a bit about those?
Yeah, and I think that this is an area that is just really beginning to explode onto the scene as awareness raises amongst patients, primary care physicians, and surgeons. Particularly, I would say plastic surgeons are the most involved at this moment, which makes sense. Although there are other general surgeons, vascular surgeons, because of their background in lymphatic disease, venous disease, who are getting involved. But the mainstay, the primary surgical procedure, I would say, especially for earlier stages, is liposuction. Okay, and they're developing are techniques that they believe are lymphatic sparing liposuction.
Right, because typically with liposuction, one of the risks is having some edema or some swelling after that.
Exactly, and that's sort of a tricky thing. And there are a few technologies that are being used, water-assisted liposuction, that sometimes you'll hear it called wet jet, where sort of a fan-like projection of water is sprayed out of the very narrow caliber, small cannulas that are used for the liposuction. That's believed to move the lymphatics out of the way and just selectively suck up fatty tissue. There's also something called PAL, power-assisted liposuction, where there's an oscillating or vibrating cannula, which is also helpful in breaking up that fibrotic tissue that we talked about, which makes it very different than cosmetic liposuction, where patients don't have that kind of fibrosis. So those are and it's done under what we call tumescent anesthetic,
right?
Which is an advanced procedure, which is a lot safer in some ways, because a lot of times now patients don't need general anesthesia, and there's a mixture of saline solution, lidocaine solution, and often epinephrine to keep bleeding down.
Right.
So it can be done with the patient actually awake, which is amazing.
And actually, just for the average person, so what is, at its core, what is liposuction? Is it literally just sucking out
Suction
fat?
of the lipo.
Yeah. That's correct.
No, like just for the average person, because I think some people, in their mind, they don't know what it looks like. So,
So you would evaluate the patient's body habitus, see what their shape is in the standing position, a lying position, and mark them. So you see where these lobules and these wattles of fat exist, and then put them in a lying position and numb up that area with that tumescent anesthetic. And then through tiny, tiny incisions, you can pass long, what we call cannulas. They're basically like metal drinking straws, if you will. And that's hooked up to a suction source. And you're basically going in and out of the tissue along the length of the limb. In this case, it's the lower extremity generally. And that machine just sucks that excess fat out. It's really quite remarkable. And a lot of fat can be removed that way.
and so what would be the caliber of the straw? Like a couple millimeters?
Yes, I would say a couple of millimeters to several millimeters.
Okay.
I'd call it a tube, not a straw, just for my own.
Sorry, metal straw users.
Metal tube.
So later when I go get a smoothie.
And is there a limit to the amount of fat that you can remove per session? So is this something, say the goal of the patient was like, I want to lose 5 kilos of fat or whatever. Do you say, okay, well, ideally we're going to do a couple and then see how it goes and then do it again? Like, is there risk with a greater volume of fat being removed?
Yes, obviously there can be health risks. So you need to be experienced. This is not a procedure that I do, but plastic surgeons are very experienced in knowing how much volume they can safely remove. And you have to take into consideration the patient's age, their underlying health status, how much fat tissue they have deposited on the body. So sometimes you do need several sessions of this to get the patient safely to where they need to be or want to be. And the key here is that this is not just a body sculpting procedure. You're also going to see, in many cases, significant reduction in those symptoms, the bruisability, the tenderness, the pain, and all of those issues.
Okay, now like any surgical procedure or invasive procedure, there's lots of benefits often, and there are some risks. Can you just quickly run through what some of the risks are with this procedure?
Yeah, bleeding is always a risk with any kind of surgery. I would say that that's not a huge concern with liposuction because you're not getting down into any of the deeper areas of the body where you have arterial blood flow, major arterial blood flow. So in the fatty tissue in the subcutaneous space, which is between the skin and the muscle, there's a layer of fat that surrounds our whole body. And in that space, it's pretty forgiving. There are some small veins and things that can be disrupted, and you can get some bruising from the procedure, but that shouldn't be a major problem, bleeding, but it's something to be concerned about. And of course, infection. Whenever we do anything invasive on the body, the surgeon wants to be extremely careful about prepping the patient, draping the patient, and protecting them from any kind of outside bacteria, fungus, et cetera, getting inside the body where it can cause an infection. And then one of the major concerns here, although with these newer techniques it seems to be very, very well controlled, would be swelling because of the disruption of the lymphatics.
I had a patient in the office. I was seeing her for knee arthritis, and she had some swelling, and she'd also had liposuction within the last 6 weeks, and she was experiencing swelling from that. We had a tough time determining, is the swelling, is it in the knee, is it coming from the knee, is it a complication of what you had done, and also with some of the pain, where was it coming? So it can be challenging to look at that.
And
stuff.
some of that is going to be normal, just inflammatory reaction to the surgery. But what you want to make sure is that you're not developing what we call lymphoceles, where you can have a collection of lymphatic fluid, or seromas, where there are collections of serum under the skin, and those have to be managed and dealt with in various ways if unfortunately they occur. But those are real concerns, yeah.
Now, you mostly talked about the lower leg, but obviously we know that from the categorization that we did before, that it can occur in the arms and can occur in the abdomen. Are those locations amenable to liposuction as well, or is it really more restricted to the lower body?
Those are definitely amenable to liposuction. And in these areas, especially when you have advanced stages, like a stage 3, where there's lobule formation and very, very large amounts of abnormally deposited fat, you can also develop what we call laxity of the skin, or loose skin in those areas after they've been sort of deflated with having the fat been removed. And so then in the arm area, oftentimes a patient will need an additional what we call brachioplasty, where an incision is made to resect that excess hanging skin to give the patient a nice contour again. Otherwise, you're going to have really a lot of very dramatic hanging skin. And also in the thigh area, you would get a thigh-plasty or a thigh lift, it can be called. In the lower abdominal area, abdominoplasty. So sometimes surgical resection of the excess skin and even some of that fatty tissue is very helpful and valuable.
That was actually going to be my next question. So say someone says, listen, I don't want to do liposuction, and I have a lot of lipedema fat. Can you just surgically excise it along with the skin to make it more cosmetically appealing? Is that an option, or is it a problem that doesn't lend itself to that?
It's an option, but it has to be done in the hands of somebody who's really highly experienced to make that decision properly. There's a middle ground too, something that's called manual extraction, because one of the key components of lipedema versus normal obesity is these nodules that are formed. Okay. Starting in stage 1, the patient's skin may look perfectly normal on the surface, but if you examine them properly and carefully with light palpation, you'll feel peas or pebbles under the skin. And those nodules will grow with time.
And is that fat, or is that fibrous tissue that you're feeling?
It's fat surrounded by fibrous tissue, which is creating these nodules, almost like a lipoma gets formed. But there's many, innumerable, too many to count. And then in stage 2, they might get to the size of a grape or a walnut. In stage 3, they could be the size of a plum or even bigger. Okay. So one of the things that surgeons specialized in this area know how to do is evaluate those patients, knowing that that's not going to come out through a suction cannula. Right. That's not going to come out through that tube, especially because of the inflammatory tissue around it. It's very hard to liquefy and to extract. So they'll make small incisions and actually push it out from underneath
almost like
the
pop
skin.
It like a pimple almost.
Exactly, and it looks quite dramatic. You can find many videos on YouTube of people performing that manual extraction technique, but you can imagine for the patient what a relief it must be to get rid of all of those inflammatory, painful fat lobules. It's really quite dramatic. And again, that's an area where afterward, if a huge amount of fat has been expressed through those openings, a resection of skin might be necessary.
Wow. Okay, so we've got liposuction, then we've got where we might have to open and extract some of these walnut-sized or plum-sized. I really wish they would use like ping pong ball and billiard ball.
I do like walnuts and plums.
Right, not anymore though. Brad's not going to eat any more walnuts.
Our prune video,
plum.
people are like, what?
So, and then you got the sort of resection that comes with it. Anything else now along that spectrum of surgical treatment for this disorder?
Well, again, there are these procedures that are referred to as debulking procedures. Right. It's a little bit more aggressive, and that's where a qualified person with a lot of experience might decide to simply excise those lobules or wattles in the outer thigh area, the inner thigh, inner knee area, etc., just as you would resect a soft tissue tumor, for example.
Now, is recurrence an issue with any of these or all of these procedures?
Yeah, I think that's a definite concern. This is a chronic progressive disease generally, incurable, like many diseases that we treat, unfortunately, but it can be managed and taken care of. The other surgical procedure that we should probably mention that I think patients would have questions about is what about the role for bariatric surgery in these patients? And that has been looked at and tried, and I think in the right patient, again, it's probably a reasonable thing to do, but generally what experience has shown is that bariatric surgery is better used for the patient, and this is why it's so important to go to an expert who really knows how to diagnose you properly, who has generalized obesity in addition to lipedema, because the bariatric surgery is going to be much more effective in reducing the fatty tissue, which is normal obesity fat, as opposed to this inflammatory fat.
In a sentence, can you just tell our viewers what you mean by bariatric surgery?
Bariatric surgery would be a surgery that is meant to restrict calories and therefore lead to dramatic weight loss, generally for people with morbid obesity, although in recent years it's become more lax, the indication. But when we were all much younger, when I was a general surgical resident, for example, we were doing bariatric surgery in 600 and 800 pound patients, specialized tables and instruments. Today it's people who can be much smaller than that, but the indications still have to be proper. And
so it's a procedure on your stomach to restrict calories.
Yeah, on the stomach, and to some degree also, depending on what operation, the intestines. That can affect absorption as well. So it can just decrease the amount of food you can take in, and also how well you absorb calories and nutrients. And it can be very tricky, and it can have a lot of complications.
And in this day and age, we have to talk about GLP-1 inhibitors and agonists and Ozempic type medications that are taking some of that market or some of that treatment away from the bariatric surgery people.
Right. So the GLP-1 agonists, I think, are also being looked at very, very carefully because it's a very hot area, and many people are enthusiastic about using them to lose weight. It's definitely been used in the lipedema community with mixed results. Again, I think that generally speaking, just like you see as a result of the bariatric surgery, it's a little disappointing because that fibrotic inflammatory fat, just like it doesn't respond the same way to diet and exercise as normal fat, it doesn't seem to respond to the GLP-1 agonists the same way or bariatric surgery the same way. It's really stubborn.
It's refractory, right? Yeah.
Exactly.
And I think that's what's unique about it is that it hurts like other fat doesn't hurt. And that's why I think it's harder to treat because it's just different kind of fat.
Yeah. And again, it brings me back to a really important point. If you go online and you look at some of the before and after photos of some of the folks who are specializing in lipedema surgery, liposuction, the debulking surgery, the manual extraction, et cetera, it's not like looking at a cosmetic surgeon's before and afters. In many cases, they're not nearly as dramatic, and you sort of say to yourself, wow, like that doesn't really look all that impressive, and I don't know if I were the patient, would I be that thrilled with that result? But the key is, having had many patients who've had these procedures, the key thing is symptomatology. Patients feel much better. They have much less pain. And in many cases, it doesn't take a dramatic amount of reduction in the right areas to help with ambulation, mobility, the ability to get around and walk. So don't let the pictures fool you to think it's purely what you see is what you get, because there's much more to it.
And you've said it a couple of times, and I think it's worth mentioning again. You need to have someone who specializes or has a very unique special interest in this area in order to have successful treatment. Is that fair to say?
Absolutely, 100%. In fact, in northern New Jersey, where I practice, because of the nature of my practice as a venous and lymphatic specialist, I get a lot of these consultations. And I'm working with a colleague that we trained together in general surgery, who's now been practicing plastic surgery for 25 years, has done thousands of cosmetic liposuction cases, and I'm trying to get him to help to develop a surgical center there.
Right.
But we both are acutely aware of the fact that he needs specialized training before we take on those kinds of cases.
Got it.
Wow, that's lipedema. Hey, that's a good
In a
summary.
walnut shell.
In a plum. Okay. Those weren't visions of sugar plums, that's for sure. So,
It's very Christmassy.
anything else to add before else? You sort of talked about what it is, the symptoms, how to treat it conservatively, how to treat it more aggressively, some of the complications that can happen, the fact that it can recur. Anything else?
I would just suggest that anybody who's interested in the subject go back to the first video we did together.
We'll put a link to that.
With all of the staging, the typing, the conservative therapy. But we did this really because there was
A lot of
huge
questions.
demand for more about the surgical options, which I think will be more and more prevalent and accessible to patients in the coming years, fortunately.
One quick question. If this is lipedema, what do you call edema in the lips? We used it. We used lipedema. We can't use it anymore.
It's 2 words when you say it like that.
Angioedema.
There you
We
go.
talked about
In the
that
lips?
From what do you call it? Allergic reaction,
Okay.
right?
That's right. But now you know. I'd say one of the take-home messages is know that this is common. This is a real thing. It is not in your head. And see someone that's going to validate your symptoms and your condition to help get you treatment. And now you know there are options. And if you like it, please like this video. Share it with someone that you know that maybe has this or was wondering about it to help them.
Be careful though. You don't want to send this video. I think you have this. Just
No,
in case
I'd
they don't.
agree. But maybe if they said they think they have
Yeah,
it, then you could.
that's
Yeah, I
bad.
agree. You don't want to be sending it
Yeah.
out to your whole mailing list for sure.
Yeah. Remember, you are in charge of your own health.
And thanks to Dr. Chubak for joining us again and enlightening us.
Always a pleasure, guys.
We'll see you next time.